Thank you, everyone, and greetings. It's my great pleasure to be with you to present with my colleagues about ways to improve patient safety. As was mentioned, I am the Vice President of the Anesthesia Patient Safety Foundation and a passionate patient safety advocate. I'm going to talk to you about perioperative handovers and how we can try to get them right. I do not have any financial conflicts of interest. I do have research grant funding that's based in the United States from the agencies seen on the screen and have the relationships shown on the screen as well. I want to share with you some current patient safety priorities from the Anesthesia Patient Safety Foundation. There are a number of different ways that we think about safety, and so these 10 areas are the ways that we think about prioritizing our efforts. Now, as I consider handovers, I think that they relate to at least these patient safety priorities, but as someone who does research in handovers, I could tell you, I could probably relate handovers to all of our safety priorities. But the point of this slide is just to highlight that effective communication when we transition the responsibility and accountability for patient care, as we do in handovers, really relates to many different areas of safety and perioperative care. I would like to submit that handovers are more complicated than you may think. Sometimes people think of handovers just as communication, just as the transfer of information from one clinician to another or from one team of clinicians to another, but they're actually procedures that are much more complicated than that. So I'll share with you a mnemonic or a memory device to remember the ways in which handovers are complicated, and that's a rainbow with 7 different colors. Those 7 different colors or 7 different stripes of the rainbow correspond to 7 different functions of handoffs or handovers that come from human factors engineers in the United States. Emily Patterson, who's at the Ohio State University, and Robert Weirs, who has since passed away, who was at the University of Florida. In the interest of time, I will not go over each of these concepts, but the objective of this visual is to show you that there are many different ways that handoffs operate. So information transmission is part of it, but handovers are also a way for us to communicate with our teams and to make sure that we're providing care safely. When we think about the evidence surrounding handovers, there are a number of studies that really highlight the importance of handovers in patient care. And so what I'm sharing with you is a way that I tend to think about handovers and their importance, highlighting some seminal studies that are illustrative of each point. So going from top to bottom on the left here, the overall premise is that healthcare errors cause preventable patient harm. And there are a number of studies that demonstrate that even though patients come to us for help, they come to us to get better, there are errors that can happen in the process of healthcare that can cause them harm. Now, when we think about the source of those errors, we realize that those errors are mostly attributable to problems or defects in communication. And the statistic that I think of most comes from the Joint Commission in the United States that attributes 70 to 80% of all healthcare errors to communication. Stepping forward, handovers are a type of communication activity, and they're particularly prone to defects, in part because they are so complicated, as I shared before. And when we standardize handovers, we improve handover quality. And I apologize here for going back and forth between handoff and handover. I tend to say handoff in the US. But we know that when we standardize these procedures, we improve their quality. And ultimately, when we improve that quality, we improve patient outcomes. So this is the premise that supports what I'll be discussing. But the idea here is that when we make handovers more robust, we improve patient care and patient outcomes. So we want to figure out how to do that. I do want to spotlight for you that there are multiple types of handovers in anesthesia care. And so what you're looking at is a figure that shows all of the different places that our patients tend to go. And highlighted in blue are some of the places where we have the most handovers. We have handovers within the operating room, within the intensive care unit, within the post-anesthesia care unit, and then between these settings as well. When we think about handovers and we think about making them more effective and more reliable, we really ought to specify what type of handover we're thinking about, because the handover procedures that we follow and the procedures that we use to standardize the handovers really may need to be setting specific. So it's important that we have the right kind of setting in mind. When we think about intraoperative anesthesia handovers in particular, the evidence base about this type of handoff is relatively weak. And so what I'm showing you is the body of evidence. And apologies if I've missed any studies, but this is most of them. And the fact that you can see them all on one slide tells us that there really aren't that many studies. And I have the pleasure of working with Dr. Jeffrey Cooper, who did some of the seminal work in the 1980s. And I've spoken with Dr. Cooper, who said that he'd wish that people would have continued, but it took us a little while to figure out that we needed to continue to pay attention to handovers. But we are seeing an acceleration in interest in this space and in studies that are aiming to improve the quality of handovers. What we know from the evidence that is published is that there is a mixed signal about whether anesthesia handovers cause harm. So some studies show associations between what we call complete intraoperative handovers and harm, meaning that there is a transfer of patient care and accountability from one anesthetist to another, where the anesthetist who's relieved does not come back. I'm going to show you a systematic review and a meta-analysis that shows that there is a strong signal of harm, but there is a recent notable study that was published in the Journal of the American Medical Association that showed there was actually no harm associated with handovers in a randomized trial. That being said, the preponderance of the evidence does associate anesthesia handovers with patient harm. And so what you're looking at here is a systematic review that was published in the British Journal of Anesthesia recently, and they ultimately reviewed 8 different studies, but were only able to use 4 of the studies in a meta-analysis. And so what you see in the lower part of the slide is a forest plot that demonstrates the risk between the risk associated with anesthesia handovers and harm. And there is a pretty strong signal here that there is something about these anesthesia handovers, even after you control for the length of surgery, the time that the surgery started, the type of surgery, the patient's comorbidities, there's still a signal that anesthesia handovers are associated with harm, and that's something that we really need to pay attention to. Interestingly, there are some studies that show benefits, not with those complete handovers, but with duty relief handovers. So when we relieve each other for short breaks, either for coffee, which I particularly enjoy, for lunch, or for some other reason, that we actually improve patient care and patient outcomes. And the theory behind that really has to do with being able to maintain vigilance. And it's difficult for us to maintain vigilance for long periods of time. So when we offer each other breaks, we renew that ability to maintain vigilance. And for those of you that are interested, I'd encourage you to go back to some of Dr. Jeffrey Cooper's work that showed that when there were handovers, that sometimes the person who was coming in to relieve a colleague would notice something that the person who was being relieved had not noticed. So they might notice that the anesthesia vaporizer was empty or near empty. They might notice that the blood pressure looked like it had been trending down over time. And so there are some really important theoretical benefits to handovers that I think we need to consider as we try to make these procedures more effective. Now, I'll say that I don't think it's surprising that the evidence on handovers is mixed. And I think the way that I process that I think about that, is that handovers are complicated. And one implication of that concept is that it's not clear that all the different studies on handovers are actually examining the same exposure. So in an epidemiologic framework, if we think about the relationship between exposures and outcomes, each of those studies that's looking at an anesthesia handover may be defining that handover differently. So some of the studies look at handovers between attending anesthetists, those that are leading the anesthesia care team. Some of the studies look at trainee handoffs, so residents in the United States. Some of those studies are looking at certified registered nurse anesthetists. Additionally, we don't know, especially for the studies that are large, the studies that have hundreds of thousands of patients in them, we don't actually know anything about the quality of the handover or what the handover procedure involved. And so it's not surprising to me that some of those studies will be mixed because it may not be a comparison of equal exposures. Secondly, I would say that we still don't fully understand interactions between handovers in the context. So, contextual factors in surgery that may be important to handovers and to communication, and the interaction between them and the relationship between handovers and outcomes are many. And so, some of them include the patient and the patient's comorbidities, the type of surgery that the patient's having, the types of clinicians that are interacting. And so handovers between colleagues who have the same professional training and experience may be very different than handovers between someone who's very experienced and someone who is less experienced. Again, the handover type is important. So if we're handing over within the operating room, that interaction between clinicians who are performing the same role is very different than a handover that may happen for a patient who's going from the operating room or the operating theater to the recovery room, where the handover may be between an anesthetist and a recovery room nurse. Similarly, monitoring and rescue mechanisms may be different in different contexts. Dr. Shapiro just talked about office-based anesthesia, so the handover that I might give to someone in recovery in an office-based setting should probably look different than a handover that happens in a hospital, but we still don't really understand how important that is. And then finally, organizational culture and resilience are important as we think about the relationship between handovers and outcomes. So, for example, organizations that do not have a strong patient safety culture may need more guidance in a handover than organizations that do. And I would say we still don't yet know how all of those concepts fit together to either support patient safety or to potentially undermine patient safety. Still, even in the setting of mixed evidence, I would say we know intuitively that handovers do confer risk in some situations. They also confer possible benefit. So I think it's possible to take what we know and to offer some guidance about how to move forward. So you might ask yourself, are checklists the answer? And I would say we have a lot of evidence that supports that checklists can be very effective in guiding behavior. And there are some notable checklist successes in healthcare. And so I'm mentioning two of them here. The use of a central line bundle that Peter Pronovost, when he was at Johns Hopkins, pioneered. And this was work that was done largely in the state of Michigan in the United States. And then the Safe Surgery Saves Lives checklist that was pioneered by Dr. Atul Gawande, that took place all over the world, that showed that use of a safe surgery checklist improved outcomes. So you might say, let's improve handovers, let's make them more reliable using checklists. However, if you look at that same evidence, you'll find that there have been some very notable checklist failures in those very same settings that I just told you about. So there was an interesting study led by Dr. Mary Dixon Woods in the United Kingdom that tried to match what Dr. Pronovost's team did in Michigan. They called it Matching Michigan, and showed that there was no effect of a checklist using a central line bundle on patient outcomes, and actually a signal toward harm. Similarly, in Canada, there was a group led by Dr. Urbach and colleagues that used a pre-surgical checklist and found in a multi-center study that there was no effect of the use of a checklist on patient outcomes. So I would take away from this that I think checklists can be a useful tool, but they are unlikely to be a single panacea, a single answer to making sure that we are taking care of patients safely and effectively. So if checklists alone are not the answer, then how should we ensure effective handovers? So what are the best practices given what is known now? We should create expectations about handovers, including using a structured approach. One approach to structuring handovers is called IPASS, which is an initiative that was started at Boston Children's, but has since been tested in multiple studies or multiple centers around the United States. The idea here is that there is an expectation for who should participate in the handover and how they should interact with each other. And this has been shown to improve patient outcomes. Another example of expectation setting is an operating room to intensive care unit handovers. This is work that my team has led that has shown that creating expectations about who should participate in the postoperative handoff and what they should talk about improves the quality of information transmission, and secondarily improves clinician satisfaction with the handover procedure. Secondly, I would say that we should facilitate easy access to clinical information to allow clinicians to focus on unusual aspects of patient care. So we know from human factors engineering that there are a limited number of concepts that the human brain can process, that the human brain can hold in short-term memory. And so for patients and procedures that are very complicated, it may be that a handoff or a handover overwhelms the brain's ability to process all that information. So what we could do is facilitate transmission of information by presenting information to clinicians in a way that allows them to decrease the cognitive burden of processing that information. A related concept here is called charting by exception. And this is a concept where nurses, for example, when they're doing documentation, only document the things that are unusual and don't document the things that are normal. So one way that this could play out in a handover is using the electronic medical record to support these handovers. So what you're seeing here is from a paper that was published by Dr. Hong Mershon and colleagues that highlights a collaboration between the Multi-Center Handoff Collaborative, which is a group in the United States, and an electronic health record vendor. And what they did was create essentially a data display that's meant to facilitate clinician handoffs, so that when there are two clinicians that are handing off to each other, that they can pull up this data display and look at it together. And what's nice about this is that they then don't have to say all of this information. They both have a common point of reference. They can look at the screen together, and then the topic of the conversation can focus on what's unusual about this patient or what is expected to happen, and that can decrease the cognitive load associated with the handoff. Thirdly, I would say that we need to be thoughtful about when handover should occur. When I look at the literature on anesthesia handovers, you'll see some papers that say that we should minimize handovers all the time. I think that is short-sighted because there are some very good aspects to handovers. And so we don't want to lose those benefits by completely avoiding handovers. I would say that there are times that are appropriate for handover and times that are less appropriate. So my recommendation would be to encourage handovers when clinicians are fatigued or otherwise impaired. So if someone is not performing well, it would be in the interest of safety to hand over responsibility for that clinician's patients to someone else. And that is something that we should encourage. However, there are critical times during procedures when handovers should not happen. And that may be because a patient is unusually complex. It may be because the surgery is in a particularly critical time. And I remember during some of my research talking with neurosurgeons who were very disturbed when they looked over during an aneurysm clipping, for instance, and saw that the anesthesia team was handing over. And so, if there is a really critical time in the surgery, that's probably not the best time to do a handover because the anesthetist should really be focused on what's happening during that important time. So as I conclude, I want to highlight some outstanding questions that remain about anesthesia handovers. Perhaps we can address some of these in the question and answer period. I think that we still need to understand what handovers warrant the most focus. We need to understand what reliable approaches are to improving perioperative handovers. We have some ideas, but I think we need to test some more. I think we need to understand how handover effectiveness should be measured. I apologize for that typographical error there. There is not a one-to-one relationship between handovers and outcomes. It's possible to have a good handover and a poor outcome. It's also possible to have a poor handover and a good outcome. And so we really need to understand what multiple measures will indicate when our handovers are effective. And then finally, we need to understand how clinicians should be trained to carry out effective handovers. And some of that training should leverage what we know about team training, for example, what was talked about by Dr. P.N. Smith. So that's it for my remarks. I thank you for the opportunity to present to you and look forward to the question and answer period. Thank you so much.